Thank you for joining us for this session, Managing Symptoms Throughout the Continuum of Care. Symptom management during and after treatment is critical, and the physical and emotional suffering is not a necessary part of your cancer experience. Dr. Lori Spoozak, a gynecologic oncologist and palliative care medicine physician at the University of Kansas, will provide a thoughtful discussion on the use of palliative care in conjunction with your curative therapies. She will explain the difference between palliative and hospice care, when each may be appropriate in your care, and the role hope plays in this cancer journey. Thank you so much for being here, Dr. Spoozak. I'll turn it over to you.
Hi, my name is Dr. Lori Spoozak. I'm a doctor at the University of Kansas Health System, and I am a specialist in gynecologic oncology and palliative medicine. And I'm here to talk about palliative care and hospice. And I'm so grateful for this opportunity from the Ovarian Cancer Research Alliance. I've worked with them through our woman-to-woman program and was able to present this to a group of mentors. And I'm so excited to be able to share it for the whole conference today. So what is palliative care? I stole this slide from HPV vaccine site because I think it's just as important as the HPV vaccine. I feel like it's life-saving and it's critical and it's what every woman needs to know. I am going to share about palliative care through the stories of a couple of my patients who had ovarian cancer and who I saw as their palliative care doctor, and one of my practice partners saw as their gynecologic oncologist. And I'm going to try and share a whole bunch of information about what palliative care is through their voices, through interviews that I did with them. And I want you to know that while this is storytelling, it's also backed up by a huge body of research that shows the multitude of benefits of early palliative care. And so, but I think it's also really great to hear it from another patient like yourself, like your family member, from their core story. So we're gonna talk to Dorothy and Petra about their experiences with palliative care. So this is what a lot of people think about palliative care. So here we see this cartoon, oh, he's our new palliative specialist, and it's the Grim Reaper with a stethoscope. And I'll tell you that this is because palliative care grew out of the modern hospice movement from the 60s. And so a lot of people have seen the growth and change of palliative care over time. What started as care for dying actually has turned into care where we have realized that the benefits of all of those tools, all of those skill sets applied to people with serious illness way earlier in the disease course actually can change their quality of life. And so when we ask our patient, Petra, how would you describe palliative care to another patient? This is what she said. Before I received palliative care, I had the wrong idea about it. I thought it was hospice, end of life care. And that made me afraid. There needs to be more education about what palliative care is. It's not something to be afraid of. You have to have a serious illness, but the earlier you do it, the better. I couldn't have said it better myself. So this is the contemporary definition of palliative care from the Center to Advance Palliative Care. And it shares that palliative care, also known as palliative medicine, is specialized medical care for people living with serious illness, not dying from it. And that's hospice care, right? It focuses on providing relief from the symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. And palliative care is provided by a team of palliative care doctors, nurses, and other specialists who work together with a patient's other doctors, like their oncologists, to provide an extra layer of support. It's appropriate at any age and at any stage in a serious illness and can be provided along with curative treatment. What does Dorothy say? How would you describe palliative care to another patient? They seem to be experts in quality of life and managing symptoms. It doesn't matter if you're currently in treatment or not in treatment. It doesn't have to be at the end of life, although it could be. So this is what the experts say about the differences between palliative care and hospice care. As you can see, the interdisciplinary team is critical because palliative care grew out of hospice care. It requires physicians, nurses, social workers, chaplains, staff from many different disciplines to work on quality of life. But here's the key difference. Palliative care can be provided to patients of all ages, all diagnosis and stage of illness, and the patients can continue life-prolonging and disease-directed treatment. Whereas hospice, a patient must have a prognosis of survival less than or equal to about 6 months if the disease takes its course, and you're going to stop doing disease-directed treatment like chemo or radiation when you convert to a hospice plan of care. So here's some big differences. Palliative care most frequently happens in the hospital setting, but a growing body of research says, hey, it's even better if we do it in the outpatient setting in the clinic early in a patient's diagnosis. So while it's the most common right now in hospitals, I do, for example, outpatient palliative care, and I see a patient along with their oncologist, whereas hospice happens in the home. That's like the biggest group of patients are in home hospice. And then hospice can also come to different places like nursing homes, sometimes an inpatient hospice unit. Palliative care is like going to any other doctor or a nurse practitioner, and it's paid for by your insurance in the same way. Hospice is a benefit that looks like a very specific group of qualifications that Medicare has suggested that hospice requires. And I'm not going to go into all of those today, but just know that palliative care is like any other doctor's visit. So this is my favorite slide. If palliative care is not just about death and dying, then what do we actually do in palliative care? So I want to flip that whole image of the Grim Reaper with the stethoscope on its side, and I present you with the Chill Reaper, okay? When I think about palliative care, I'm thinking about, while I'm also dealing with the grief and the seriousness of illness, I'm focused on joy and like thinking about how we can live our best lives. So I'm here in this cartoon, we see the Chill Reaper in their tie-dye saying, dude, why so grim? Chillax, okay? So a lot of people come to the palliative care clinic worried that we're going to talk about death and dying, but instead, actually, we talk about so much more. And so that's what I hope to share today. So palliative care assessments, or an extra layer of support along with your disease-directed care. So what does that mean? So I'll tell patients, okay, your oncologist is thinking about at their visits that cancer-directed therapies. So when you go in there, they're worried about your labs, your chemo dosing, what's your side effects from the chemo so I can change your dose, or your radiation plan. And what I'm going to take off their plate is all that stuff around the cancer-directed care that we just don't have enough time for. And I'll tell you, in my own gynecologic oncology practice, there's just simply not enough time in a 15-minute visit to manage all of these things along with your cancer-directed care. And so this is where palliative care can come in and offer that extra layer of support. So we work on physical function and debility assessments, your emotional health, your spiritual health. We talk about prognosis, or how much time you might have if you want to talk about that. We talk about values clarification or cancer coping, symptom management. We support caregivers. We think about who's supporting you in your social health. So these are all of the areas that we investigate and figure out how we can do better for our patients and take it off the plate of your oncologist. So Dorothy, I asked her, what do we do together in our visits? Dr. Spoozak and her team talked to me about the quality of life. That's her #1 concern. They want to make sure I'm not in pain, I can eat, I can sleep, I have energy. And then we talk about what's best for me. We discuss the pros and cons of treatments and clinical trials. So how do we do this in our visits? So I like to say, and our nurses like to say, this is our vital signs. So when you go to your oncology visit, you're going to get your labs checked. You're going to get your vital signs checked. And while those things are important and they might guide different medicines we prescribe, the most critical thing at our palliative care visit is checking in on how you're feeling inside yourself. Okay, so this is a tool that we use at all of our visits, the Edmonton Symptom Assessment Scale. We look at your pain, tiredness, nausea, depression, anxiety, going down this whole list, and we check in at each visit about where we are. And the reason is that they've done research to say that most people are not aware that these are symptoms that they should tell their doctors about. And they're also not aware that there's a lot of things we can do about these symptoms to try and help you live a better life. And so we want to work on these at each of our visits. So when our symptoms are managed, they're tamed, then we start thinking about, how do I live in this body with cancer, sometimes as a chronic illness? So what I see, actually the most common group of patients in my palliative care clinic are those patients who are living with cancer as a chronic disease. And this is really different than the narrative that's most common about cancer care, which only presents cure or dying. And actually, it's probably the largest growing group of patients that we have now because of maintenance therapies like PARP inhibitors and other drugs that I probably shouldn't say in my presentation that are like immunotherapies and targeted therapies. They're keeping people alive longer. They're delaying recurrences. And we're living in a totally different type of cancer care for so many patients. And so how do I reconcile my life knowing that I have a serious illness inside me, that I'm uncertain about my future? So we think a lot about goal setting at our visits and finding joy in the body that I have right now. We're so lucky to work with a patient and a family who actually made this goal worksheet. We talk about things like, what are your long-term goals? 1 week, 1 month, 1 year. What are you doing in your short-term goals, in your spiritual well-being, your arts and crafts, your chores, your social activity, your mental activity? What are the things that we can work on together to make a big picture plan so that you live your best life in the body that you have right now? So I like to call it life coaching with serious illness. That's what we've sort of evolved into for a lot of palliative care. Dorothy, how has this changed your relationships? So Dorothy says, it has helped my family relationships. Dr. Spoozak was able to calm my fears. Then I was able to pass that information and feeling on to my children. It helped them understand and get in a place where they can accept what's happening. I could turn around and use her words to talk to my children. I think it's helped them treat me differently. They respect my wishes and understand that I'm not doing something wrong. So a lot of our patients are focused on living scan to scan. What does it mean to not be sure of what's going to happen next? So a lot of people have scanxiety. That's a term that's come up a lot. And we have to figure out, how do we cope with this cancer? Whether or not your scanxiety is coming from being in a remission where you're worried about your next scan, or that you have that cancer that's there in your body and you're worried about if you're going to stay on this treatment. We use many of the same tools to figure out how to cope with cancer. And so these are the things that we talk about and we remind you and we share resources about. Sometimes those are apps, sometimes we talk through and work on anxiety mitigation techniques, sometimes that's medicine, goal setting. And then this is a wonderful project through Mass General, the Continuum Project, that created a coping card for patients to work through. So we asked Petra, how has palliative care helped you, or has palliative care helped you with your cancer? Absolutely. She helps me with the stuff the oncologist doesn't have time to deal with: anxiety, sleep disturbance, pain management. It's nice to know I have another doctor to talk to. When I first met her, I was a mess psychologically, and I feel 10 times better than I felt before I saw her. What's the greatest way palliative care has impacted your life, Petra? Well, stress and anxiety management, the stress that comes from having this illness. Anxiety is harmful, and she helped to manage that. This is so common. Petra and Dorothy represent all of our patients in the stress of illness, and palliative care is here to help you with those stresses. So we had some important questions that came up from our mentor discussion about palliative care. The first one was, when is the right time for palliative care? And we're going to get to that. And then also, when is the right time for hospice? Because it's like, how do I figure out when to do what? And so we're going to go through those. So the benefits of palliative care, which I hope you've heard from our patient stories, are the greatest when it started early. And when I'm sharing these things through patient stories, and I'm sharing them through anecdotes, but I want you to know there's a huge body of research that supports this. That early palliative care, the earlier in treatment, in the outpatient setting, in the hospital, early on admission, it will change your outcome for symptom management. It will change your outcome for your mood, your anxiety, depression. It offers benefits to caregivers. Some studies in the past have suggested maybe there's some effect on actually improving, or at least not making worse, your survival. A lot of people are afraid, if I do palliative care, I'm going to live less long. Well, actually, the opposite is true, that actually people live just as long and maybe even longer if they're exposed to palliative care. So I want you to know that earlier is better. Here are some bright lines for when you should ask for palliative care, or hopefully your doctor's thinking about palliative care consultation. If you have a high burden of symptoms at any part of the disease course, and any of those things that we talked about on that scale, even on day one, think about a palliative care consult for yourself. If you're diagnosed right away with a stage 4 or metastatic cancer, or another word is cancer that spread, is another way that people talk about that, you should think about a palliative care consult, because usually that is overlapped with a lot of symptoms and distress. If you have recurrent cancer or cancer that's come back, that's another way that we commonly talk about it. You should think about palliative care, because when we have more treatment, it's like we're carrying around a backpack of symptoms. And with each time we go through we go through a new treatment, we throw a new symptom in that backpack, and we have to carry that with us. Well, what we hope for in palliative care is that actually we're going to try and unburden that backpack of symptoms and make it a little lighter for you, so that you can keep going through your treatments and feel better while you're going through, additional treatments. If you're needing help figuring out when to change or stop disease-directed treatment, palliative care is here to help talk you through that. We're experts in communication. We want to think through what your values are and what the risks of treatment are, and we help you weigh those things that you're hearing from your doctor. And here's the last thing. You are entitled to a palliative care consult whenever you want to see palliative care. It's your right to request a consult or referral in the hospital or clinic at any time. So the truth is, it doesn't matter. If you like the sound of palliative care, please ask your doctor for a consult if it's available to you. So I'm going to pivot now about when we transition to a hospice plan of care. So our vision for how palliative care works is that palliative care comes alongside your doctor while you're getting disease-directed therapy. And as we see here, sometimes you might need more palliative care in the sense of more frequent visits. I've had patients who graduate from palliative care and they only come back to us years later when maybe their disease comes back or they're having more symptoms with their disease. And so we see that over time, the intensity of palliative care and those needs becomes greater as you're approaching the end of life. It's my job as a palliative care doctor to sense when that transition might be happening to something that we call the dying phase of illness. So I'm going to kind of talk about that as a cue for us to think about a transition to hospice care. Prognosis, or forecasting time and death, is really important. And we have tools to help us with this. Many times people ask, how much time do I have left? And I'll tell you this, the internet will not help you figure this out. Looking at databases for 5-year survival doesn't ever help. The only thing that we can do is look at your body and how you're doing over time and how you're responding to different treatments over time to tell us how much time you might have left. And so I'm going to kind of give you a little bit of a roadmap. So I'll argue that we don't need a CT scan or a lab test to tell us when people are in the dying phase of illness. So why do I say that? Some people might be at the start of their treatment and have stage 4 cancer that's spread all over, but they feel fine, okay? Some people might have a CA-125, which we're all familiar with as a lab test, that's really high, but they feel great. So here's the bright line that I want to offer to you about what I know about when people transition into that kind of dying phase of illness, and that you can tune into to think about, maybe I should start making different choices now. So when people have weeks to month of life, we see some common things. We see that you start really slowing down. Your energy becomes severely decreased. You're spending more than half the day in the bed or chair. You're sleeping all the time. And it's not because you don't want to participate. It's not because you don't want to move your body, but your cancer is actually taking all of your energy from you, and it's not possible to get that body in motion. We see at the same time usually severely decreased appetite, no desire to eat, or eating really minimal amounts. We see that folks start having difficulty walking or dressing or bathing themselves. They have a hard time getting to appointments. Something I commonly see as a shift is that someone who's been walking into their visits in palliative care, I've seen them for years, all of a sudden they show up in a wheelchair. And that's because function is everything. Function tells us all about how someone is doing and their time in their illness. And it's truly the only way that I can prognosticate that someone is moving into the dying phase of illness. And I share with people who are living with chronic cancer that it is part of my job as a palliative care doctor to identify that change. And I take that off their plate of worries, because as long as they are highly functional, walking into my office, whether or not they're taking treatment, I don't see that they're in that dying phase of illness. And unless something catastrophic happens, it's really hard for any doctor to predict that. So I just want to say that this is our bright line here for when we start thinking about a hospice plan of care, okay? When we start thinking about a hospice plan of care, that is also the time to start thinking about when to stop chemo or disease-directed treatments. Here is the hardest thing to wrap our minds around. When the body is weak and when the body is dying, chemotherapy and other cancer-directed therapies can actually take time away from us. And that is not something that our mind can adjust to. Our big, governing bodies that suggest guidelines for treatment, like the ASCO, the American Society for Clinical Oncology, or SGO, they suggest that if somebody has very poor function, they shouldn't be getting further treatment. But many times it's really hard for us to reconcile that this same treatment that's been giving us more life, longer life, and less symptoms, all of a sudden is not going to do the same thing. And so I want to help you understand that this is the hardest conversation for patients to have, for doctors to have, for family to have, because all of those things that have been tied to longer life, all of a sudden, when the body is weak, actually end up shortening time. And that is a big time to think about transitioning to a hospice plan of care. That's when hospice is appropriate, because if we manage our symptoms, if we manage our function and get you the support you need to your home, people feel better and live the way that they want to live for the remaining time that they have left. So what does hospice actually require? So we talked about a prognosis of 6 months or less if the disease takes its natural course. And I would argue that we kind of really know that months of time based on the things that we would say that we learned earlier about prognosis and when we might enter that dying phase of illness. So we do our best, but hospice just says 6 months or less. Goals of care shift toward quality of life, not prolongation of life, meaning we're not going to be thinking about disease-directed treatment anymore. We're not going to be thinking about chemotherapy, immunotherapy, targeted therapy, because we know that actually those things might harm our bodies at this time. And so we're going to focus on symptoms and alleviating suffering as our primary goal, getting you time with family, being in your home and getting care coming to you. Symptom control focus is the key as opposed to trying to fix the underlying cause. So many people, for example, if you have pain, we're not going to keep scanning your body to look for where that pain is. We're just going to be treating your pain because we know that when you have enrolled in hospice, that it's because you have a life-limiting illness, and that is the cause of that pain. And so we're not going to keep doing the same old thing that we did before. We're going to refocus and shift on ways of treating the symptom as it comes. So where does hospice happen? The most common place is at home. Sometimes people have a hospice residence, but you do have to pay for room and board. Sometimes it happens at a nursing home. You either pay for room and board at the nursing home, or sometimes your insurance will cover that, with hospice coming to the nursing facility. There's an inpatient hospice unit in many hospices. I think about this as like an ICU for hospice care. And what does that mean? It means that you have severely uncontrolled symptoms or needs that require active medication management with IV meds and intensing nursing intervention. And actually, most people don't qualify for this kind of care. Or it's a short stay in an inpatient unit, you get tuned up and then you go back home, which actually is most people's preference anyway. So the hospice benefit in the home looks like this. Adequate home support is necessary because most often family needs to be your primary caregiver unless you can afford an aide. So your care team is a nurse. Hospice is a nurse-driven service, and they're excellent, and they get to know you really well the longer you have on hospice, which is why we try to get people on hospice for many months of time, so you get to know your team, and they get to know you so well that they can say, we need to fix this pain med, or we need to fix this nausea med, and they get to know your family really well. And the nurse can visit 1 to 3 times a week, and that's symptom dependent. Sometimes they can come in for crisis care, but that's pretty limited. They provide a limited access to home health aides, usually if they're available 2 to 3 times a week, but less than 5 hours a week. And usually it's for like a bath or something like that. A social worker is dictated by needs. A chaplain is available and dictated by needs. There's volunteers. There's a medical director that oversees the whole plan of care. But really that nurse is who is communicating with the medical director. Hospice provides durable medical equipment like a hospital bed, oxygen, and medications related to that diagnosis for symptoms. They provide a comfort pack of medicines that are the most common things that come up as someone is dying from a serious illness. So I'm going to pivot back to say that I really hope that we've learned about the differences between palliative care and hospice care. I hope that you're empowered to ask for palliative care. A lot of folks in our mentor lecture talked about the fact that they're not sure if they even have palliative care, and in some places they're for sure that they don't have it. So here is what I would empower you to do. If you do not have palliative care, I want you to ask for it. I want you to encourage your doctors and your health system administrators to recruit palliative care trained doctors and advanced practice providers to your hospital and clinic. Patients have a very strong voice in medicine, and hospice and palliative care these types of services, they should be provided everywhere because we know that they provide strong benefits. And additionally, palliative care upfront and early in any kind of serious illness care provides those to an even greater extent. And so we really want you to share this message with your doctors and your healthcare system administrators to change the culture of healthcare for the better. We want you to educate your doctors because a lot of times doctors have an old-fashioned view of palliative care because, like we talked about at the beginning, palliative care grew out of the hospice movement. And so a lot of folks don't even know what contemporary palliative care has to offer their patients. And so I want you to also feel empowered to ask for it if it's at your facility. Like I said, anyone can ask for a palliative care consult at any time. And additionally, you also have the right to say, in my body right now, I feel like it's time to transition, knowing what I just learned about when it's the right time to transition to a hospice plan of care. And you have that right to share that with your doctor and to have that conversation with your doctor about treatment. And so I hope that this whole talk has helped empower you to be able to take more control over your quality of life while you're walking through a serious illness like cancer. So some important links. So we've made at the Woman to Woman at the University of Kansas Health System website some videos about cancer care, but also podcasts about palliative care and living well with cancer. And we did these with our mentors that we trained through our Woman to Woman program that was generously funded by OCRA, and we're so grateful for it. It's really changed the lives of so many of our patients. The other website is Get Palliative Care. And at this link, it links you to local providers in your region that provide palliative care. And it's something really to think about if you don't have at your hospital, trying to advocate for. And I just want to say thank you and close. This is my first group of our Woman to Woman mentors and our coordinators. And I can't tell you how grateful we are at the University of Kansas for having that experience and for me being invited to even talk about these things that I'm passionate about. I'm so excited about all the work that the OCRA is doing for patients, families, and for physicians like ourselves to make care better. So thank you so much.